So this is the last case for the day. I'm Dr. Aman Patel. With me we have my mentor and my role model, Dr. Sanjay Shah, who is the course director of TRICO since the last 20 years. And Professor Abdurashid is the reason why this program has developed so well in our institute in the year 2024. With his clinical support, we were able to perform 24 VAL cases last year with successful in-hospital outcomes. Last year, as he was not available, we were not able to do a live TAVR course in TRICO, but this time we have two cases. First case is today and the second will be the first case tomorrow morning. Professor Abdurashid sir is the clinical lead in the Department of Structural Cardiology at UMC Heart Center in Astana, and independently he performs over 300 VAL cases every year. He has been doing transcatheter valves since the year 2011, and the entire team of our hospital is eternally indebted to him for his kind support. Dr. Manik Chopra, who is sitting in the panel, has also been of a very kind clinical support to us since the last 4 months, and we have performed 5 extremely high-risk cases with his support. So let us go to the case now. This is the case number 7. He is a 66-year-old gentleman who presented with a progressively worsening dyspnea on exertion. Currently he is in NYHA class 2 on medical management. He has a history of acute anterior wall MI last year, for which PAMI was done to LAD, and check angio show the patent stent in the LAD with non-obstructive epicardial coronaries. On 2D echo, he has a normal LV ejection fraction with a mean gradient of 49 millimeters of mercury and aortic valve area of 0.7 centimeter square by VTI method. His STS crom score is less than 4%, meaning that he is at a low surgical risk. His valve appears tricuspid, but actually it is bicuspid, because if we look at the CT, there is a small raphe which fuses the non and the right, which fuses the left and the right coronary cusps.
Where is your slide?
Can we go to the next slide, please? So this is the baseline CT scan and the Clemenceau report. The annulus area, the diameter derived from the annulus area, the area is 605 millimeters square, and area derived diameter is 27.8 millimeters. The valve is type 1A bicuspid, and the aortic valve calcification is severe. We do not have significant significant raphe calcium, but the subvalvular calcification is severe. The fusion is between the left and the right cusps, and the LVOT calcium is on the left as well as the right, extending from the leaflets to the LVOT. However, the non-coronary cusp and the subvalvular area around the non-coronary cusp is not calcified. If we look at the data of such bicuspid aortic valves, the outcomes are similar to those with tricuspid aortic valves. We will come to that later. Next slide, please. So this is the valve background. You look at the first image on the left. It looks like a tricuspid valve, but there is a fusion between the right and the left cusps, and you see the raphe in between. The importance of this raphe is that when you are expanding the transcatheter valve, the raphe is something which cannot be distorted. Even a surgeon cannot cut it with a knife. So when you inflate the valve, and if you calculate the valve area purely based on the annular diameter, then sometimes the raphe restricts the expansion and the non-coronary side gets the maximum pressure, and that can cause aortic injury post-procedure. On the second image, you can see the aortic annulus, and you see the maximum and minimum diameter of the annulus. The importance of these diameters is that if you are planning a pre-dilatation, usually pre-dilatation is a rule in patients with bicuspid aortic valve. The balloon diameter that you are choosing has to be smaller than the minimum aortic annulus diameter achieved on a CT. Here the minimum diameter is 25, so we will be pre-dilating with a 20 or 23 millimeter balloon. The next is the LVOT. You can see the calcium towards the left. And next slide please. Sinus of Valsalva diameters are good. The right coronary has a great diameter, left is slightly on the lower side, but due to the good sinus diameters, we do not expect coronary obstruction in this case. Next slide please. So in bicuspid aortic valve, you do not entirely depend on the annular diameter. You have to calculate the diameter at the annulus 4 mm, 6 mm and 8 millimeters above the annulus, because in such patients with tapered anatomy, the anchoring zone is not at the annulus, but it is at the level of the raphe. When we are planning to implant the valve, our goal is to be 80 to 90% aortic and 10 to 20% ventricular, so that we do not embolize the valve into the left ventricle. Next slide please. So this is the same three-mention. Next slide please. Professor Abdurashid, can you explain about the raphe in this?
Yes. Here and so such great conference, TRICO. For me, it is great pleasure to be here with Dr. Tejas and his team. And you can see here that it is a bicuspid aortic valve type 1, roughly between the left and right coronary cusp. It is a moderate calcification, and also we have some calcium in LVOT from the left coronary cusp. Next slide. You see? Okay. Now you can see here.
Yes, so
okay.
If we look at this conclusion, based on the ICD, that is the intercommissural distance, the intercommissural distance is 27.3. If you go at the annulus level, then we should go with a 29 millimeter valve, but in tricuspid valves we tend to oversize by 10 to 15%, but in bicuspid valves we tend to undersize up to 6%, and we can even go down to 0% or negative if we feel that at the anchoring zone there is a high risk of trauma. In this case, if you see that if we go with a 27.5 millimeter valve, we are minus 1.8% sizing. When you add extra fluid to the inflation device, every cc extra fluid in the device causes oversizing by 2%. So our goal is to go 27.5 plus 1 so that we get a 0-0 coverage of the valve. Next slide please. So these are the femorals, they appear good, and we use the right femoral access for the sheath. We did ultrasound guided puncture with a micro puncture needle, and the left radial has been used for the pigtail because the power injector is closer to the left radial. Next slide please. So sir, can you explain about the design of the valve that we are going to use?
Okay, this valve is unique, and we start to use this valve from 2021, and now we have about 4 years follow-up, and I can say that we have a very good follow-up. And the big advantage, next slide, of this slide is they have intermediate sizes which you can use more accurately when you are choosing the size of valve. For example, in this case, if we use, for example, Edward Sapien, and 29 is oversized more, but 26 it is more downsized, and sometimes you need more, something between these two sizes. And these valve have extra skirt which prevent PVL and bovine pericardium used in this type of valve. And okay, next.
So these are the various sizes in which the valve is available. If you compare it with a sapien, the benefit is that you have multiple additional sizes which are intermediate. So you don't tend to significantly oversize or undersize and get some better hemodynamics. Next slide please. This is the navigator transcatheter heart valve delivery system, and this is used to deliver all the myvalves. It has a steering which helps us to cross the aorta precisely without scratching the aortic calcium, and it can potentially reduce the risk of a post-TAVR stroke. Next slide. This is the delivery system. Next slide. The valve is crimped over the delivery system. This is the Python sheath, which is actually a 14 French sheath used for the femoral access. The benefit, the name Python, it's called so because just like a python engulfs its prey, this sheath can engulf any valve up to 32 millimeters. And it expands with the valve up to 20 French and then collapses back to 16 French and then back to 14 French. Next slide. This is the over-the-wire mammoth balloon that we usually use for pre-dilating in bicuspid cases. Next. So coming to the echo of this patient, the mean gradient by echo is around 49 millimeters of mercury, and Pmax is 4.6, suggestive of severe aortic stenosis. Next. The ejection fraction looks good. The valve is severely calcified. Next. Next. This is the subcostal view. We usually take a subcostal view on the day before we go for a procedure, because after the procedure we need to make sure that if we have any collection in the pericardial space, we have to rule out a perforation. Next. Go back please. Now we can start with the case. We'll come to the data and the further presentation after the case is over. Thank you.
Yes. Okay, if you have some questions, comments from your side.
So, hi Dr. Abdurashid, this is Dr. Manik.
Hi Manik, nice to hear you.
My only concern is that the CT scan which was shown was analyzed in 75% phase, and we know that these numbers are diastolic numbers, and probably the systolic numbers might be slightly higher than what you got in the diastolic phase. The area derived was close to 27.8, and maybe if you are higher than this, and we know that there is a LVOT to annular calcium, so with 0% of oversizing, if there is a PVL, then we know that there is no other way to stretch this valve further, the 27.5, because you have already taken +1 or +2. So that one concern, and also I found that probably at 4 millimeters, if you stretch it slightly more, the intercommissural distance was close to 27.7 or something. So maybe, I'm not sure. These are few things I would like to add, but I believe that it should be good with 27.5 also.
Okay, thank you. It is very challenging to measure and to do TAVR cases with the bicuspid aortic valves, and of course now we have different techniques how to measure, and if we measure 4, 5 and 6 millimeter above of annulus, as you know, the anchoring zone for this for such kind of cases is a little bit above of annulus, and that's why let's see, let's do maybe first pre-dilatation with the balloon. After that we'll see how the leaflets where the commissures and will crack, and how the leaflets will move, and after that we can decide more precisely. I agree with you, Dr. Manish. Now we are going to do...
Let's cross the valve now. So we are going to cross the valve with a Lima catheter. You can see Lima is slightly at the higher side, and in this cusp overlap view, you can see the leaflets opening. So I am going with a 038 Terumo straight tip wire, and I try to go towards the non, where there is the empty space, towards the center. And we have entered the LV cavity now.
Stiff wire, please.
So would you like to do any hemodynamics now, or we just do it once?
Yes, we will be doing a hemodynamics first.
Okay, measure the pressure. Yes.
So, Dr. Manik, for balloon expandable also, you would always do a predilatation, is it? Even if it's bicuspid?
Not,
even this
visible
anatomy?
on the camera, so I would request somebody to focus the camera on the hemodynamic screen when we are showing it.
Yeah, I would agree with you. Like for bicuspids, you would always like to predilate so that there is no milking of the valve during the valve deployment. So anyway, this is a balloon expandable technology. The final balloon size is 27.5. So whether we take a 23 or 25 should not be a problem. I think they are going to take a 23, so that should be good. So.
Aman and
would LV dysfunction or an elevated LVD modify your decision?
Can I ask a question just for the audience here? Can you give us a little bit more about the setup? Is the patient under general anesthesia or moderate sedation? Do you have a transthoracic or a transesophageal echo monitoring strategy? Just to paint the picture for us.
Can we start this? Can we see the pressures?
I think we are not audible there, so make sure that we are audible there if possible. And in the meantime, I can answer that for you. This probably is under local anesthesia with sedation, and their routine strategy is with the transthoracic echo if they need.
This one.
So bicuspids, yeah, go ahead.
In the meantime, this is a very elegant way of crossing. Lima catheter as such, we all are more happy with AL1 and AL2s, but Lima catheter off late, since last 5-6 months also I've started using Lima catheter, and it helps really to cross it easily. The only thing is I prefer a Teflon coated wire so that I have more control to exactly where I go, but for sure they were able to cross it very easily. Yeah. You were saying something, Dr. Ajay?
Yeah, I was saying that for bicuspids, actually what we do is we have a minimum and a maximum. So as you said, we take measurements along, and you know what you should not exceed, and you know what is your minimal size. And so we'd use a combination of what the CT shows, which is always a bit of a compromise, because however, whatever measurements you make, there's a little bit of guesswork involved, unlike the tricuspid valves. And you'd say that, as you said, we will not go beyond a 27.5 plus 1, whatever happens.
Now we can see the.
So we'll probably do a 27 and then add another.
So you can see the hemodynamics on the screen now.
Yeah, looks really nice.
Aortic pressures are around 90 millimeters systolic, and LV pressure is 146. So peak to peak gradient is around 50 millimeters of mercury.
Okay.
So it is the severe aortic stenosis. Now we will be exchanging the Lima, the Safari extra small wire.
And here also we'll use wire pacing.
Yes, to make it minimalistic, we are going to pace the left ventricle with crocodile clips. You need to give some support.
Fix the wire. Fix the python sheet, please. Usually we cross with a 14 French python. It is much safer, and even for big sizes of valve. And after that, we could post dilate with a 18 French dilator. Okay.
So when we are exchanging the sheath, you have to make sure that at least one operator fixes the wire so that the wire does not pop out.
The aorta looks really horizontal to me. I don't know the angulation, but
angle, I think it's around 45.
Oh, okay. If this is like LAO, if it is a coplanar view, then really
this is cusp overlap view.
Yeah, looks pretty horizontal.
Relax.
So we constantly keep the fluoroscopy on to make sure that the wire does not pop out. Otherwise, we have to repeat all the steps again. So this is the python sheath going in.
Okay, fix the python. We cross very smoothly without any resistance. Fix. Okay.
So for the audience,
so now
you'd like
Professor
the...
Abdurashid is taking out the dilator and fixing the wire. As soon as the dilator is out, I will fix the wire. So this is the coordination that should always be there between the operators.
18 French.
So you need the Merrill facing upwards, and are you going to suture the sheets to the groin?
Yes,
Yes,
yes.
yes, yes. As the valve that we are going to use is larger than 26, we will dilate the 14 French python sheath with a 16 French dilator,
18 French.
18 French dilator, so that passing the valve becomes easier. I am pushing the dilator and Professor Abdurashid has fixed the safari wire.
There's interesting differences in technique. We would put the sheath in
Now
before we
he's
cross
pulling
the
back
valve.
dilator and I am fixing the python sheath. He is also fixing the wire while pulling the dilator.
So that's the Edwards
The
E
fluoro
sheath
is
that you speak
constantly
of.
on, so that somebody has an eye on the wire.
That's the Edwards E sheath that you put before.
Yes, in this python sheet, sometimes when you go directly with the 18 French balloon, please, sometimes you damage the distal part of the sheet, and when it is difficult to cross, and also you could damage your light stitches.
Aman, Professor Rajiv Gulati wants to tell something.
Yes, please.
Oh, it was just a comment on the difference between the Edwards sapien technique in that we would leave this wire in the descending
Increase the
thoracic
volume,
aorta
please.
to put the
There's
sheath
no way to
in,
increase the
not
volume.
leave it in the ventricle.
So can you
Is there
say
a reason
again
why?
the volume problem?
It was just a minor comment that with Edwards sapien we don't cross the valve until the large bore sheath is in.
Right, right.
Any particular reason why you want to leave the wire in the ventricle? It's just more room for error this way?
It is a different techniques. Sure, you could first put the stiff wire to aorta. After that, you could go and insert the big sheet. After that, the cross. But when we use 8 French sheet, and after that you cross through the valve, and after that we use the python sheet. I think it is much faster, and I've never saw any problem with it. Now
It's also about saving the cost of one super stiff wire.
not cost, but time. Time is, I
So-
think, more expensive than cost. Okay, Zuro?
Now we have the mammoth balloon across the valve,
More?
and we are going to attach crocodile clips and paste through the LV wire. Can you show this?
Are you planning to do simultaneous aortogram as to see the balloon inflation and the...
Yes, yes. We need to see the behavior of the leaflets.
You mean angio during the inflation? I think it is not necessary. Sometimes we are doing this angio when we have, high risk of coronary obstruction, and when it is a borderline size. Okay, we could do it here.
It just because of this size concern
Yes,
that Dr.
yes,
Manik
okay.
raised, I think it was a
Okay.
very valid concern.
Okay, good. Let's do it.
Repeat after 15 minutes.
Fine. We'll do contrast. When balloon inflated fully, after the contrast.
Negative.
Let's check the pacing. Pace 110. Pace on. Now pacing is working fine.
Yes, it is.
Okay, and one pressure line here. Okay, fine. Go. Fine, good. Activate
So we are
injector.
going to take a simultaneous injection.
After full inflation of balloon. Now it's ready.
Okay.
Ready, go.
Pace on.
Sinam.
Pace at 180.
180 pace on.
Now you look at the blood pressures.
Can we see the fluoroscopy, please?
Going down.
Can we
Pace
see the
200.
fluoroscopy? They're showing us the hemodynamics.
Pace 200. Show the fluoroscopy there.
Sinam.
200.
Stop pacing. Stop pacing.
We are not getting good blood pressure.
Okay. Let's
Please show the audience
scalp.
the fluoro screen along with the hemodynamics.
Scalpel.
Right.
So, Dr. Manik, you have switched to LV wire pacing.
Sorry?
I mean, for balloon expand, because most of my work is with proctoring, and every center is a new center, and there is always a challenge with pacing. So initially, for most of the cases, I stick to temporary pacemaker. I would say the way to go is you do few cases and then try with self-expanding and then finally with balloon expanding, because then it would be unforgiving if something goes wrong.
You know, when we know that patient have a high risk of AV block, at that time we use RV pacing. Ready? Okay.
Pace at 200.
Pace on.
Somehow it's not picking up. Yes, it's pacing now.
Good.
Now look at the blood. It's going down.
Sinam.
Go up.
Contrast.
Deflate.
Okay. Stop pace.
Pace off.
Pull it back. Okay, let's see.
The valve is ready. So when we predilate, sometimes if patient develops acute AI and you don't have much time to go with the valve, so at the time of predilatation we should keep the valve crimped and ready.
Okay, let me pull back. And with the 20 balloon, there is no any aortic insufficiency with this dilated valve, and I think we'll use 27.5.
So I noted that even with the balloon the balloon going up, I saw that there was a loss of pacing, and we were watching the balloon bob up. So that would be a disaster if it was with it.
Earlier. Well,
we agree 27.5 should work well here with this picture with the balloon valvuloplasty.
Yes, we'll use 27.5. Dr. Manik, what is your opinion, audience?
No, I agree with you for 27.5 for sure. I would also agree with your strategy on wire pacing, because I think you routinely do it, but for us, like, it's slightly, you know, our since the volume is scattered at different centers, so you know, each center doing like 5-6 cases a year, so it's we still are more comfortable with the temporary pacemaker in.
Now we are going with the valve.
Show please the arch, aortic arch.
Now when you go to the arch, you have to slow down and start flexing the delivery system.
Yes, I pull
so
back.
The valve remains central.
Continue.
And you don't scratch the calcium on the aortic wall.
Fine. The implantation, I think it will implant in cusp overlap view. We can use also, you know, coplanar view, but in patients with type 1 aortic valve stenosis, usually it is better to use cusp overlap. And as you see, as you saw, during the balloon predilatation, the waist was a little bit higher, and I think the anchoring zone here in bicuspid aortic valve is a little bit higher, and that's why we are going to implant a little bit higher. Go cross. Now we are crossing.
Now the middle marker is parallel to the pigtail.
Now?
That is unlocked. This is locked.
Okay. What do you think about the position of the valve? I will push a little bit. Good. Fine. Fine. Fine.
So when Professor Abdurashid is pushing the wire, the valve comes slightly out.
Let's do one angio.
So,
Synap.
okay. Now we are doing one angio to confirm.
Okay. 180.
Good. Pace 180.
Okay, wait.
Just 1 second, let him connect the
Scalp. More.
Right.
You're ready.
I'll go a little bit deeper maybe. Yes. Fine. More. Okay. Let's see coplanar view. Okay, cine and one angio.
One angio in the coplanar view.
Okay, fine. Cusp overlap view.
One more angio.
Wait. And this is where you can. And caudal. Okay, one more angio. Fine. Now, my opinion is that the valve position is not bad. What do you think?
I think it's good, and I would also go with an RL cusp overlap view so that we know if the valve is shifting to the non-side due to raphe, we know when to stop. Yeah.
Okay, fine. Let's pull maybe a little bit higher. Okay, pace
Okay,
on.
start pacing 180.
Inflation technique is important here.
Wait. Angio. Little bit. Okay, let's go.
Go up all the way.
Wait.
Deflate.
Wait. Stop pacing.
Pace off.
Now, blood pressure is recovering.
To take out
Slowly.
the balloon slowly. Some support.
Okay. Duro?
Start some fluids.
Okay. More contrast. Urgently. Okay, now we pull back.
Show the hemodynamics, please.
Now we are pull back the delivery system.
Rhythm is
Now it's fine.
okay.
contrast is finished, you know, when it is. Let's see.
Do we need to wait 3 minutes like we do for the sapien valve? Allow the outer skirt to be active? We routinely wait for 3 minutes before doing the aortogram. Is that bundle branch block new? Probably.
Probably yes.
Show,
a new bundle branch block.
Show please. More. LAO. More. So. Okay, fine. Now, ready? Sorry, but contrast finished. And
Dr.
okay.
Sheed, do you routinely have to wait for this valve, like for the my valve, like we do for sapien valve, for about 3 minutes before the outer skirt really does its job?
We start in 2011 with core valve and the first generation and Sapien XT, Edward Sapien XT, and till 2018 we work with these two valves, and but cost is very high for Edwards in our country, and that's why it is a very good alternative for Edwards, I think. Fix. Now, wait. We want to remove stiff wire. Okay. Ima?
The power injector is ready, so you can take
More. And let's do angio without stiff wire. Blood pressure is good. Could you see the hemodynamic on your screen?
Yeah, we can see hemodynamics. There is a very good dicrotic notch. I don't expect to see a significant PVL.
Okay, go.
So we'll be exchanging this
Volume
safari wire for a pigtail now.
16. Flow rate 17. Go. Go. Okay. Fine. Duro. Fine. Ready? Ready?
We just need a pressure line now.
Ready? See now?
So now the LV pressures are visible on the screen.
Ready?
Yes. We don't see.
You mean now here you can see there is a cusp overlap view that implantation height seems good. Let's see in coplanar view.
There is no parallax in the valve right now, so this is good. We didn't see the aorta opacification enough, so difficult to.
You see, it
comment
is a
on
really,
PVL.
I agree that this is a horizontal aorta. Even when we start to implant the valve, it goes a little bit more horizontal. LAO view.
The root
And
is
a
a little
little
big,
bit
so we may need to
yeah.
use more contrast.
The root is almost like 40, 42
AP.
minimum.
So we need to use more contrast to fill it up.
Can we increase the contrast
AP.
during the angio?
80. Fine, good. Let's, this is a AP view. Go a little bit deeper. Ready? From the from the left coronary cusp, there is zero implantation, and by angio, we can see maybe a small PVL, but we'll, I think, recheck by echo. And let's measure the pressure, peak-to-peak pressure.
Echo is going to be crucial here, I think, because of the risk of a PVL with the bicuspid and with the LVOT calcium. I think there wasn't enough contrast. I think if we need to really look for AR, we need 50 cc's or 40 cc's. That looks like 10 cc's. So a high quality echo will be helpful here.
Hemodynamics on the screen.
We can see the hemodynamics.
Could you repeat?
Is it we need an echo, I think, to really assess for PVL because
Yes.
the contrast was insufficient. The LVEDP looks high, but the diastolic looks okay. So I'm a little concerned about PVL. I think an echo will be really helpful here.
Okay, okay. Now you can see the peak-to-peak gradient. There is no gradient, and the diastolic pressure seems also good. Let's do echo.
Focus the camera on the echo screen. Two cc. One empty syringe.
Definitely think the valve positioning was perfect. Could not be better. Let's see what the PVL looks like.
Yes, all bicuspid aortic valves are, very challenging cases, and even that information that we have now, how to measure it, what type of valve we should use, it is still sometimes unpredictable, and totally in our institution. Annually, we are doing about 250 TAVR procedures, and about 30-35% of our cases is a bicuspid aortic valve.
So that is the echo. Can you see the echo on the screen?
Fluoro, don't press the fluoro.
Is the echo visible at the auditorium?
Yeah, we can see the echo.
Okay.
Can you flip the screen of the echo to the X-ray screen, if possible?
Press color. We can see a whiff of AR. Visible aortic regurgitation.
Okay, let's. Could you manage here? Gain in the color. Here is also you have some artifacts. Okay, 5-chamber view.
Shall we remove the lima that it's inside the LV?
I think no.
That can sometimes
No. It is some artifacts on echo probe. Let's do more contrast.
Yes.
If the renal function is fine, maybe do an aortogram with a higher volume of contrast.
Yes. We want to do one angio. Renal function is fine here. Contrast. We'll do more volume and.
Also try holding the catheter, right above the valve, because it keeps slightly moving, so then it gets diluted.
18. Here's 17, fine. 850. 850. Okay. Fluoro, please. Go down with the Go down. Little bit lay off. Stop. Fine, fine. Fine. Okay. Let's remove maybe also this one. Okay, keep it here. Little. Okay, good, good. Ready? Ready? Go.
1 second, sorry. Okay, go. Looks like mild PVL.
Yes. Okay. I think yes, we have PVL, but diastolic pressure is 60, and diastolic pressure in the left ventricle it's about 15. If we'll calculate aortic regurgitation index, I think it could be more than 0.25, and sometimes in patients with a bicuspid aortic valves, you should choose between two complications, to increase the annulus rupture or to have a small PVL. And your opinion, should we do post-dilatation or we could leave it?
My view is this is a fantastic result. That gradient is like magic. It was the huge gradient is now 0. The valve looks great. I think this is the QRS is now narrowing. PR interval is normal. I think there is a risk of post-dilation here, as you mentioned. I think this is a fantastic result, and congratulations to the whole team for this great result.
Thank you. Okay. Thank you.
So now we can go back to the presentation. Can you show the slides, please?
Wire. Yes, routine wire.
What is your vascular access closure strategy, Dr.
We are
Aman?
going with one ProGlide and one AngioSeal.
Right.
Yes, we can show.
We'll be showing you the hemostatic technique. Before that, we just go through some data which is relevant to the case that we conducted today. So this is the long-term follow-up data of TAVR in low-risk patients at 5 years. So the partner 3 extended study showed that, next slide, at the end of 5 years, the patients who underwent TAVR or surgery, who were at low surgical risk, had no apparent difference between the primary endpoints. This was at the end of 5 years. Next slide. So this is the conclusion of partner 3 long-term study, that among low-risk patients with severe symptomatic aortic stenosis who underwent TAVR or surgery, there was no significant difference between the two in terms of primary composite endpoints. But we must know that the majority of the patients who were enrolled in partner 3 were tricuspid valves. So we should not apply that data to patients with bicuspid aortic valves, because as the US FDA has already approved TAVR in patients with bicuspid aortic valve, we are less likely to see randomized controlled trials which are designed specifically for bicuspid aortic valves. Next slide. So we do have registry data based on which TAVR in bicuspid aortic valve has got the FDA nod, and that registry data is based on the partner bicuspid subgroup analysis, TVT registry, and a few more.
No, just
now this is the slide that you see is a comparison between MyVal versus Sapien and Evolute. In India, MyVal is being used since the year 2019, and the observational data and the registries that we have are showing good outcomes. But this was the 1 month outcome, the landmark trial, which was a head-to-head comparison between MyVal versus Sapien and Evolute. And 70% of the MyVals used were the first generation MyVals, and around 20% were the octa-core. At end of 1 month, MyVal was non-inferior compared to the other contemporary valves. Next slide, please. Now this is the bicuspid registry of partner 3. So when you are approaching a patient with low surgical risk and a bicuspid aortic valve, if the patient is at a low surgical risk, there are some criteria which help you decide whether TAVR should be an option. So if you look at long-term data, RAFE itself is associated with increased long-term mortality, but when you have a combination of severe RAFE calcification along with severe subannular calcification, the 2-year all-cause mortality goes beyond 25%. With one of the two, that mortality is between 7 to 9%. And this we will discuss tomorrow in detail when we are having a high-risk case with bicuspid severely calcified valve. Next slide. Okay, so that is it in our presentation. Now we'll go to the hemostasis. We had the patient's body weight is 86 kg and we had given him 9,000 units of heparin. The ACT during the procedure was around 320. The procedure was done in conscious sedation, and this is our cardiac anesthetist, Dr. Chirag Shah sir. He is actually in the operating room with the cardiac surgeon, but he will give you a basic idea about the conscious sedation that he gives, which keeps the patient conscious throughout the procedure, and the perceived pain is significantly lower. Dr. Chirag, can you please explain your method of conscious sedation, the substance that you use?
Hello. Yeah. I have given the conscious sedation to this patient, and which can be defined as the patient can respond to verbal and tactile stimuli. Here I have given 50 microgram of fentanyl supplemented with 2 milligram of midazolam intravenously. The usual dose is 0.5 to 1 max per kg of fentanyl and 0.01 to 0.02 or 10 to 20 max of per kg of midazolam. And patient is easily arousable. We can assess the neurological status of this patient also post-procedure. Thank you.
Thank you, sir. And now, about the hemostasis?
There is no bleeding here. Protamine was done, yes?
Yeah.
Okay, fine. And I think fine. It's fine. Show, please. This part.
So you can see the local site with one proglide, one angioceal, and now the heparin has been reversed. 50% has been reversed with protamine. You do not see any bleeding from the local site.
Okay.
So we conclude this case. 66-year-old gentleman, severe aortic stenosis, low surgical risk. We have successfully done a transcatheter aortic valve implantation. There is mild paravalvular leak, but in interest of the patient, we are not doing post-dilatation and accepting that leak. Thank you.
Congratulations, Aman. One more comment. You had initially, right after the valve deployment, you had a first degree AV block and new left bundle branch block looked like. Now it's reverted back to normal.
QRS is getting narrow, and I think the patient might not need a pacemaker.
Yeah, it has become normal. I think it's the baseline. So great job there. Excellent outcome.
The patient is saying that he wants to clap.
No, great result. Congratulations. Congratulations to the team.
Thank you everyone.
Thank you.
Aman, good afternoon. Dr. Pintu Nada here.
Sir, how are you, sir?
Great job you have done. Congratulations a lot of.
Thank you so much, sir. Thank you.
Thank you, everyone.
So now we will be having a panel discussion, and tomorrow morning at sharp 9 a.m. we are going to start a high-risk case, bicuspid aortic valve, severe aortic stenosis. STS risk is 13, and the patient is high to prohibitive risk, and we are planning TAVR through the right femoral. So we'll see everybody at 9 a.m. as well as for the dinner today. Thank you.